It'll take a few minutes for everyone all logged in. Hello, everyone. Welcome. Feel free to unmute yourself and introduce yourself or pop into the chat. Let us know what your role is in long-term care, where you're calling in from today. Just take a few minutes here to get everyone logged in.
Hi, this is Peter Newedek. I work at multiple long-term care centers in the Victoria area and do long-term care exclusively now. I've been in practice for over 30 years and really enjoy what I'm doing. Thanks for putting this on tonight.
Welcome, Dr. Newedek. Welcome everyone else. Feel free to introduce yourself in the chat or unmute yourself. Just give it another minute or so here while people continue to log on.
Hi, I'm Maria Stefanik, social worker in a large long-term care home here in Victoria. Looking forward to this evening's talk.
Welcome, Maria. Which care home do you work at?
I work at the Heights at Mount View.
Oh, right. Okay.
Jessica, it seems like the chat is disabled, at least for me. I don't know if it is for other people.
Oh. Sunita, can you have a look? I can see it on mine.
Chat appears to be working on mine, but
Okay.
you can't see any of the other participants.
Oh, maybe that's what it is. Okay.
If you click on maybe the gallery, it might work.
Yeah, even for me, it just says I can message the host and the panelists, but I can't. I'm assuming I can't message everyone else unless are they all? Is everyone a panelist today?
Oh, I see. It
No.
does say chat disabled on mine. The
Does
chat
it?
box shows up, but it says disabled at the bottom.
Chat is showing up disabled on my too.
Okay, well, we'll look into that. Sunita, can you have a look in the background there and try and get that sorted? In the interim, I will just do a brief introduction, get started, and hopefully we'll sort out that chat as that is happening. So I'm Jessica, the South Island, Victoria South Island LTCI operations lead. I'd like to take a moment to welcome you to our learning series this evening. It is with great respect and appreciation that I'm speaking to you today from the traditional and ancestral territories of the Sauk Nation, where I feel very lucky to work and live. So a couple of housekeeping items. Please keep yourself muted as background noise can amplify very quickly. There are CME credits available for this event. A member of the LTCI team will email you a certificate next week for your records. At the end of this evening, we will have an evaluation, so please take a few moments to participate. Your feedback is very important to us. The event this evening will be recorded and posted on our website along with a copy of the slides. If you do have any questions throughout the evening, please feel free to unmute yourself and ask away. There will be plenty of time at the end for a question and answer as well. So finally, I'd like to introduce our presenter for the evening. Dr. Amit Arya is a palliative care physician who works in hospital, home care, and long-term care facilities. He is currently the palliative care lead at Kensington Health in Toronto and also works at the Freeman Center for Palliative Care at North York General Hospital. Dr. Arya serves as a lecturer at the Department of Family and Community Medicine at the University of Toronto, an assistant clinical professor for the Department of Family Medicine at McMaster University. He is a board member of the Canadian Doctors for Medicare, as well as the Canadian Society of Palliative Care Physicians. For his relentless advocacy for health justice and human rights, Dr. Arya was awarded an Award of Excellence in Social Responsibility from the Department of Family and Community Medicine, University of Toronto, and also an award of excellence from the College of Family Physicians for Canada. He was also recognized as a change maker by the Toronto Star. He is a co-founder of Doctors for Justice in Long-Term Care, a coalition of over 1,000 physicians and researchers advocating for an overhaul of the long-term care system in Ontario. His advocacy includes education and research, an active social media presence, and coverage in print and broadcast media. He frequently presents to medical students, physicians, interprofessional colleagues, and the public. So without further ado, please welcome Dr. Arya.
Hey everyone, thank you so much for having me this evening. It's really a pleasure, and I know I see that in the Q&A box, it seems that the Q&A box is working, so maybe we can communicate that way. I think as it's a small group, please feel free to unmute yourself, share questions, comments, feedback. Let's try to make this more interactive and more of a discussion, rather than a didactic presentation, which I'm personally not a fan of. So I'll just share my screen so we can get started. So today we're going to be speaking about improving goals of care conversations in long-term care. I'll say it again, we have a lot of time to kind of have this conversation, so I hope that we'll be able to do this sort of collaboratively, and we'll be able to have more discussion. I just wanted to start off by saying that I am joining you today from the traditional territories of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and in, I guess, the language of settlers, this is known as Mississauga, Ontario. And I'm truly grateful, for all of the, for the fact that actually Indigenous communities have actually looked after this land for thousands of years. And I all feel that, in our talks and actually in our work, we should really commit to, addressing anti-Indigenous racism, which does exist across the healthcare system as well as frontline health workers. Moving on to faculty disclosure, I don't have any disclosures or any conflicts of interest. In terms of objectives, we'll start a little bit today by talking about, just the general concept of goals of care discussions. And in fact, we'll start by talking about why this is important to speak about, and why this, this whole talk I feel is quite important for all of us working in long-term care. And what are some common errors in how we see goals of care conversations happening in long-term care. We'll talk about, how goals of care conversations definitely, we should not be using this sort of one-size-fits-all approach, and we should be trying to provide, conversations which are equitable, trying to provide the best, for care as, for people and communities as they deserve it. And then we'll talk about how, of course, we don't work in isolation, and, any interaction that we have with a resident or their family is, part of a context in a bigger system, whether it's at the micro level in terms of a particular long-term care facility, whether it's at the meso level in terms of, a community of practice or a particular town or city, or whether it's at actually a much larger level, provincial or national level, in terms of how we fund and how we, look at long-term care. So we'll be taking a bit of a deep dive on that subject as well, because that's very applicable to what we're going to be talking about. Just a bit of background about me before I get started. And I obviously was hoping to interact with all of you and learn a little bit about, what your practice is like, what your role is in long-term care. But just so you know, I've worked in long-term care since 2014. I initially started working in long-term care as a family physician. I had a comprehensive family medicine practice focused more on geriatrics. I did home visits. I worked in long-term care as well. And then I retrained to, practice in more of what we'd like to call a specialist palliative care setting. And through that, I continued to work in long-term care and eventually transitioned to providing consult services in long-term care. So right now at Kensington Gardens Long-Term Care Home, which is a not-for-profit long-term care home in downtown Toronto, clinically at least, I have other roles in this long-term care home focused on education and research. But I, clinically, I provide palliative care consultations in this long-term care home. I do not do MRP work, but just wanted to give you a bit of background about, the type of work that I do, and hoping to once again share that experience with all of you in terms of where you work and what your practice is like. just wanted to start, at the very beginning with some definitions around palliative care, because of course that's, the context in which I think we'll be talking a little bit about goals of care conversations. And in case you haven't seen this before, this is the bow tie model as developed by Dr. Pippa Hawley out of UBC. And basically this talks about the 21st century palliative care model. I hope you have all once again seen this before, but the idea is that palliative care is, an approach to care which is integrated with life-prolonging measures, with possibly even curative measures or disease-modifying measures. It's not just something which is, the bottom right-hand box, which is hospice care, but rather, once again, it starts very early. In fact, nowadays, we think about the palliative care approach starting from the point of diagnosis, along with advanced care planning. And that's really what we should be thinking about in long-term care. And in fact, before people are admitted to long-term care homes in the first place. I just thought I'd provide that definition, of course, so we're all on the same page in terms of what we are talking about with respect to palliative care. Secondly, we often, sadly, perhaps describe palliative care by what palliative care is not. So palliative care, I don't think we should use it as an adjective to describe a patient. We should not be referring to patients as palliative. Patients are human beings, and they're not simply defined by their prognosis or the philosophy of care or the medical specialty, for example, that is involved in their care. We talked about how palliative care is not just end of life care, and palliative care is definitely active care. It's not about giving up or about something that will be necessarily less intensive or less harder to practice. It's not a location of care where you go to receive palliative care. I strongly believe that regardless of where you are in the healthcare system, whether you're at home, you're in long-term care, you're even in the emergency department, you ideally should be able to receive a palliative care approach. And it should not be obviously an afterthought, especially in a setting like long-term care. And we'll get a little bit into this in the slides to come. So what should palliative care look like in long-term care? At the outset, I just wanted to share this sorry, I don't know what happened there. Sorry about that. I just wanted to share this document that I led the development of as a board member of the Canadian Society of Palliative Care Physicians, and you can definitely look this up, which was a key messages document that we use to advise the national standards process, which is underway right now on what palliative care, once again, should look like in long-term care. And you can, in a way, I know our talk today is not broadly about palliative care, but you could substitute goals of care with, each one of our action items or, each one of our key messages. So, palliative care, and in terms of goals of care conversations, they should not just be based on prognosis, and we shouldn't just be providing this to people at end of life, but it should be based on their needs. We should be introducing the concept of palliative care, at least upon arrival and or upon admission to long-term care. And I would say ideally, or as it says here, before arrival into long-term care, all health workers should be able to participate in the process around goals of care and palliative and providing a palliative care approach. We should really be providing palliative care in interprofessional, interdisciplinary teams, and we should have the support of specialist teams as well when required. I can share with you, this is some research I'm involved with right now where, I know at least here in Ontario, this is my practice and my experience that commonly we have access in long-term care homes to geriatric psychiatry or some type of psychiatric support to help with behaviors, but we don't have support to palliative care specialist teams, and that's obviously a problem. And of course, when we're looking at standards and developing standards for palliative care, we should look at performance measures, QI work, and and palliative care should definitely be a core part of that work. So this is basically what our national standards focused on. So why do we need to speak about this? As many of you might already be aware, our population is rapidly aging quicker than ever. 2021 was the year that baby boomers actually turned 75. The number of 85-year-olds is going to triple by 2046. And as we know, as we get older, more and more people actually accrue more and more illnesses. Acuity and complexity is therefore on the rise in long-term care. There's this bottleneck effect as well in our healthcare system, and I'll get a little bit into that in some of the slides where we're talking about systems-related issues. But because of the bottleneck effect, people are getting sicker and sicker in long-term care facilities. And I'm not sure what you're seeing in your practice, but definitely, I can tell you through the pandemic, I'm definitely seeing that there are some people, not everyone, but there are some people who are arriving in long-term care who have shorter prognoses as compared to previous. We know that data from CIHI once again does tell us that actually the average life expectancy in Canada is around 2 years for someone living in long-term care. Most people are in their 80s or 90s and have multiple comorbidities. Life-limiting illnesses like dementia, for example, is often one of the most common life-limiting illnesses, frailty, and that's something to be considered as we are looking after people living in long-term care. We'll move on next to a case, and I hope this will just, give you a bit of an example about some of the, the issues that we're going to be talking about and emphasize the importance of goals of care. So we have here, and of course, I've removed all identifiers from any of the cases that we're going to be talking about. So we have an 87-year-old gentleman who has had a stroke, living in long-term care, and was admitted on G-tube feeds. After a goals of care conversation, the resident was actually very hopeful to actually reduce the feeds. And I can tell you this was because he was experiencing some respiratory congestion, and this was causing discomfort. He was actually having to cough up a lot of sputum and was hoping to actually stay in long-term care because he was very happy with the team there, very happy with the health workers. And then what happened after that conversation is that the resident actually aspirated and became quite sick, and became dyspneic and was coughing, and then was asked in that moment when he was struggling to breathe if he wants to go to the hospital. And at that point, he panicked and sort of said yes. And there wasn't any further conversation, and he was transferred to the hospital and sadly died within 24 hours. So I don't know. I mean, I once again wanted to make this interactive. So is this sort of a situation that, or, is there something similar that you can think about in your practice that you've encountered? Does this sound like something you encounter frequently or not at all? Okay, maybe I'll keep on going. But yeah, I mean, I have these slides with questions and sort of breakpoints, but feel free to interrupt at any time. So, I mean, moving on, I mean, I hope it's clear, another reason that we want to talk about this is, of course, it is related to health systems issues. And Canada, I mean, at large, actually, we don't do a great job in terms of providing palliative care, allowing people to age and receive end-of-life care in their location of choice, which is often not acute care and not the hospital system. In fact, we actually are the OECD leader in terms of acute care deaths. So in Canada, we have about 60% of deaths occurring in hospitals, and in comparison to some other countries, Netherlands, it's 30%. The US, even our neighbors to the south, it's just 20%. We know that actually end-of-life care, meaning spending in the last year of life, is quite expensive here in Canada. What that means is that it's a large portion of the GDP. A lot of people actually have, they go to the hospital, they get expensive tests, they get unnecessary treatments, and often they suffer a lot more in those situations as well. So it's very expensive and also not good for people often in those situations. And, right now we're having this national conversation, in case you haven't been following, and I'm sure it's the same across the country, including in British Columbia, about, a healthcare system which is under severe stress, a healthcare system which is collapsing. And of course, some of this is related to the fact that we haven't really shifted focus in our healthcare system. Our healthcare system, and even the Canada Health Act was designed to look after people who were much younger. When we look at what's funded under the Canada Health Act, which is hospital and physician care, so long-term care, home care, these sectors are actually not included. And because of the lack of focus on palliative care, and we'll get a little bit into this, oftentimes we have people who end up in acute care who don't want to be there. And of course, we have these very sad stories, which I have encountered, of course, working in the hospital, of older adults who are delirious, lying on a gurney, in the emergency department and suffering and waiting for care. And those are obviously inappropriate and situations that we would like to change. We have a comment in the chat that's being shared that says, from Nicole, thank you very much, that says there's many similar situations that Nicole has encountered. And it once again highlights the needs for early goals of care and end of life discussion. So that's actually a very, very important point. And as I said, I strongly feel it should not even be happening when someone is admitted to long-term care, but it should happen much before. These conversations should actually be started at diagnosis, and long-term care should simply be responsible for continuing the conversations from before. So once again, we know, part of the problem is the emergency department sometimes ends up being the gateway for palliative care, unfortunately. So we know that actually the majority of people who actually, often receive a palliative care approach or are first introduced to palliative care, this happens through the emergency department. And that's something that's very alarming. And even in a setting like long-term care, there are significant problems. And, we would think that long-term care, because, the life expectancy is 2 years, as we discussed. And that's also, I wanted to just take a pause there. That's quite variable. I can tell you just about a month ago, I was speaking to a colleague of mine who works in Edmonton and does a lot of research in long-term care. And he was sharing with me that in the city of Edmonton itself, the life expectancy in their long-term care homes is just 12 months. And I'm not surprised, because I would expect in certain places in the country where maybe there's a shortage of beds, particular reasons, then once again, due to that bottleneck effect, we would expect people to be getting sicker. As I said, in my own anecdotal experience, I've seen that definitely there are people with much shorter prognoses who are being admitted to long-term care now, perhaps because of many different issues going on in the healthcare system, delayed pandemic care, and so on. But Kai-Hai actually tells us that only 6% of long-term care residents were recorded as having received palliative care in the last year of life. Keep in mind that this data is from Ontario and Alberta. I suspect actually there's a larger number of people that were receiving some type of palliative care, but probably not what we would define as the early integrated palliative care approach, but rather more of an end of life care approach. And maybe there's a problem in this statistic itself, in that we're not actually collecting the right data, and we're not actually looking at the proper quality metrics for palliative care as well. Here's a great question as well. So family physicians deliver palliative care. How is this defined? So I'm not sure, Margaret, if you're asking about this particular statistic here as well. I know that to collect this data, Kai-Hai looked at specific billing codes to determine, palliative care, and to determine the designation of palliative care as well, and how a resident is, designated as receiving a palliative care approach. So once again, I feel with that there are limitations to how we're collecting the data, and we have to improve that, because of course the data tells a story. And if we're not collecting the right quality metrics, then we won't be able to improve on the type of palliative care that we're receiving, or that we're providing, in long-term care. So yeah, definitely there are issues with this, with this stat. And I think the bigger issue, to add one more point, is that we all probably know that there's a lot of variability as well in terms of how we deliver palliative care and long-term care as well. And that's a problem in itself, because the care you receive really should be more standardized. It shouldn't be so dependent on encountering the health worker, the nurse or doctor who knows what they're doing, and maybe some people don't know what they're doing as well, or is not as skilled. It shouldn't be as dependent as being in a particular long-term care home, which provides better palliative care, or much better palliative care than another long-term care home, like a few kilometers away. I mean, that's not fair, right? I think we should do better to standardize this, and once again collect better data. Once again, sharing a little bit of data about why this is important, just to give us some background, but I'm sensing, at least from the chat, that this sounds pretty familiar to all of us. We know that unnecessary medical treatments and transitions of care are sadly actually common for long-term care residents. And I can tell you some statistics from a study that was done by a friend of mine, Nathan Stahl, who's a geriatrician at Mount Sinai Hospital here in Toronto. Once again, Ontario data, because we have sort of a data set through ICES, which you can look up here, where we can easily do these big data, type of studies. And, that's something we should ideally have in every province across the country. But, basically what they found in this research is that, for long-term care residents who had advanced dementia, where even when they ask, we know from previous research that 90% of substitute decision makers, when they understand advanced dementia and they're presented with proper prognostic information, when they're presented with proper prognostic information, they want a comfort-based approach. But yet this data is quite alarming, that we know that 1 in 10 people actually visited an emergency department in the last 30 days of life. 1 in 5 people with advanced dementia from long-term care were hospitalized. 1 in 7 actually died in acute care. And 1 in 4 of these residents who visited the emergency department. So 1 in 4 out of the 1 in 10, sorry for the confusing statistics, but about a quarter actually were in restraints during their visit. So obviously, once again, we know that emergency departments are not as well suited as we can be suited to deliver palliative care. In an ideal world, once again, I would say that emergency departments should be providing better palliative care and recognizing this as well. Once again, some more stats about this, but essentially just going to the bottom line here, we know that there's an issue, and goals of care, bring it back to our topic today, which is around having better goals of, improving goals of care conversations. We know that's part of the, it's definitely part of the gap that occurs in long-term care facilities. The national statistics is sort of at the bottom here, where about 1/5, 21% of patients from long-term care were admitted to acute care for palliative care. And once again, that's from CAI. So moving on a little bit into goals of care conversations, and I'm going to go through these next set of slides a little bit quicker, because I'm assuming, of course, as people who work in long-term care, this is, a skill set that we all have, familiarity and experience with. But just to give us all some background and get us once again all on the same page, we know that this is obviously a very vital skill set across the healthcare system, especially in a setting like long-term care. And, it's something that we can learn, something that we can improve on. It's something that we can receive mentorship on. And it's very important for all health workers who work in long-term care as well. It's a vital aspect of our practice. And we know that from the patient perspective, it's something that's very, very important and can make a big difference in terms of resident and family satisfaction. It can make a big difference in terms of outcomes. It can make a huge difference in terms of building rapport. In fact, it's an opportunity to build rapport. And there's this sort of saying or proverb, which I have up on the screen here, that if you break bad news, you will always be remembered. And if you break bad news well, you'll always be remembered. Break bad news poorly, and you will never be forgotten. And this is sort of a saying which actually a friend of mine who is an advocate for palliative care through his own experiences, he's actually a journalist who his wife actually had metastatic cancer, and he shared this experience with me, and he gives these talks on grief and the importance of palliative care now. But he remembers the experience when they were sitting in the office with the oncologist. His wife was not eligible for any further cancer therapy, and the oncologist just simply said, "I can't do anything for you," and walked out of the room after I think many years of being involved in the circle of care. So this saying is pretty self-evident that the way that we speak to people often makes a huge difference, and once again can build rapport as well. And it's a skill set which has to be learned, and we have to keep on working on trying to do better. And that's something which I'm still trying to do, and we should all be always trying to do in our practice. I hope all of you have seen or heard of the Serious Illness Conversation Guide. I really do consider this, the gold standard in terms of, a starting point to, maybe improve on or learn about goals of care conversations for, if you're new to working in long-term care, or it's something you want to think about in terms of standardized language. I'm not going to read through this, but I'm just putting it up on the screen for reference. Once again, this is the Serious Illness Conversation Guide. And once again, it provides you with standardized patient-centered language. And in terms of, I've taken some training in terms of how to, educate, medical learners, medical students and residents on, goals of care conversations, and specifically with the Serious Illness Conversation Guide. And the starting point is actually, just to use the language that they have in the screen. If you're interested, you can do a Google search for a more lengthy document, which has been, developed by the Serious Illness Conversation Guide, folks. And basically that more lengthy guide even will give you patient-tested language for specific scenarios. So scenarios like, if you have someone, who's very upset and doesn't want to talk about it, if you have someone who's crying and very sad, if you have someone who's very angry, and also there is sort of some patient-tested language included in that 11-page version on CPR and code status discussions and how to have those conversations well. So once again, just sharing for reference. Here are some basic steps in terms of how to have a goals of care conversation. And once again, I'm going to breeze through this, but of course, there's some preparation work that's involved, studying, what's happening with the resident, the purpose of the conversation, exploring illness understanding, identifying who the correct substitute decision maker is, exploring patient values, expectations, and beliefs. And perhaps this is the most important slide in terms of the technique of having goals of care conversations. And this is proposing treatment or proposing options for treatment. And we'll talk a little bit about this and how to do this in the slides to come. So thinking about how this concept of goals of care conversations is supposed to work, ideally, it's supposed to be a Venn diagram, as you can see here on this on the slide, where we look at what are the treatments which are clinically indicated? What does the relevant scientific evidence show us? So what is, if we can think about, the evidence and, are the treatments we are proposing evidence-based? And how does this intersect with with patients' values and preferences? So that's ideally the place we want to come to with respect to shared decision making. And I really like this slide because this kind of shows us some of the tension that exists with having these conversations, where on one hand, we have the option of paternalism. And generally, when I see, my colleagues in practice nowadays in long-term care and even in other settings, we don't really see paternalism nowadays very much. It still happens, but we see it much less. And paternalism is when the physician or nurse practitioner will just kind of make the decision for the resident or the family and tell them what's going to happen. That's not really something that's once again happening nowadays, I feel, as much. But now we've swung to the other end, which is consumerism, where we often see these scenarios where sometimes we see, physicians, nurse practitioners, other health workers who are kind of absent from the decision-making process and are offering options in terms of treatment options, kind of like a menu. And that's not how it should be. I mean, and part of the problem with these conversations sometimes is that people are not making informed decisions. When I think about consent and the consent process, I think the key word is actually before the word consent, which is informed. So we talk about informed consent. People absolutely deserve to know what they're getting into. And also, as frontline health workers, I wanted to emphasize that we do not have to offer, or we should not be offering or honoring near impossible requests. So if someone has a request that actually doesn't make any sense to us clinically, then we should have a way that we can compassionately speak to people, develop consensus, but not to offer a treatment which is not clinically indicated. And this is just sort of a more complex slide about, basically what we said in the last slide about different models of decision-making. We talked about the paternalistic model where we are deciding for the resident. Obviously, that's not right. There's the informative model where I'm just providing you some facts and you make the decision and I'm absent. But ideally, we want to move to, the right-hand side where we're actually, we're like the patient or the resident is an expert, or in a case of an incapable resident, their substitute decision maker is an expert and sharing the preferences in terms of, what that resident would have wanted and what quality of life meant to them, for example. And we are proposing the right treatments that would match up to those preferences. So take a pause here. Once again, hoping to get the chat going. So what do you think, and what have you seen, or even, I would love to hear what you have learned through your years of practice or your work, your training, in terms of common errors with goals of care discussions.
Yes, my name is David. I'm in Victoria. Can you hear me?
Yep, we can hear you. Hey, David.
Good. So yes, so I'm a family physician and I work part-time in long-term care. I retired from my own practice 8 years ago here in Victoria, and I just provide long-term care in 2 facilities, and that's sort of my final chapter, if you like. We here in Victoria have a core group concept where there is a smallish group of physicians who provide care in most of the nursing homes, and I'm the core group in a couple of homes. So people who come under my care, I have no background with them. Previously, I would have looked after people for 20, 25 years. I would then follow them into long-term care.
Right.
And over those years, there's been an understanding and a trust developed. Now, I have to get that up to speed very quickly when I first meet these new people and their families. So that really is a skill which I'm still developing, I think, to develop that trust with these goals of care discussions. And so when a clinical condition changes very quickly, and I make a recommendation to keep their loved one in the nursing home, in most cases, that is accepted because I've been able to develop a relationship with the substitute decision maker or with the resident himself, herself. But sometimes I just feel that I haven't yet quite made that relationship concrete yet. And I'm thinking of one that happened about a month ago when someone ended up in hospital. An elderly man entered in hospital and died there about 5 or 6 days later. And I really felt that I hadn't maybe developed that depth of relationship. So the substitute decision maker just didn't feel comfortable keeping her brother in the nursing home. So that's something that I'm kind of working on and working to improve as I continue in this.
Yeah, thank you so much for sharing your experiences and, for sharing, in particular, what happened in that particular circumstance. I wanted to just say a few things, just some comments, about what you brought up, which is really important. I mean, speaks about a systems issue, which we'll talk about a little later, but the importance of primary care, where we know that primary care, to be very honest, is quite broken in our country. And right now, I don't have a lot of hope that it's going to get better. But there's so many things that even I see. Once again, as I mentioned before, I worked as a comprehensive family physician, and now I work in specialist palliative care. But there's so many things that would be done better with primary care, because care is a relationship. This is something where you're absolutely right, whether it's goals of care conversations or really any aspect of the healthcare you're providing, it's based on, developing trust. It's based on, human connection. It's based on, so many different things, which, once again, develop on that, building that rapport. And it's a lot harder to do that if you don't know someone from before the time that they became sick. So that's really great. The other thing I wanted to share is that, we're not aiming for perfection here. And I can really tell that you're trying your best. And that's, I think, what we should all be trying to do. But yeah, I mean, definitely I've seen my colleagues who work as family physicians, nurse practitioners, once again, in long-term care, go through some very challenging scenarios where, they're really trying their best to develop rapport. But unfortunately, sometimes even people are admitted and they're quite sick from the get-go. And it becomes quite challenging. Or there are situations where there is mistrust in the healthcare system from even from prior to being admitted to long-term care. And we're kind of on the tail end. We're on the back end of the healthcare system. So once again, some great points that were, brought up. I have a comment here from Kat, which says, getting ahead of the resident, talking about levels of intervention before ensuring he or she understands medical conditions. Yeah, so that's absolutely true. And we have to kind of, speak about what's most important to the resident rather than our own agenda. Ideally, that's what should be happening, unless, of course, we understand if it's an end of life scenario, your back is up against the wall. Well, maybe you have to change that paradigm in that moment. But in most circumstances, then, that's not what we should be doing. We should be building rapport. We should be exploring illness, understanding first. Great comment here from Christine, which says, I think we all agree in most cases, the needs of long-term care residents are better met outside of acute care hospital settings. Sometimes people feel guilt. Absolutely. People feel guilt that they're abandoning their loved ones by not sending them to the hospital, and they don't understand that the hospital does more harm than good. So thank you so much for that. And Sharon sort of says that, yeah, important to start the conversation on quality of life as soon as you meet them. Yeah, so thanks so much for sharing some of these comments.
Yeah. Oh, wow.
Yeah, and anything else to add from anyone else?
Mm-hmm.
Okay, so we'll keep on going here. So here are some common errors, which I have on the screen, and I hope you can relate to some of these. We already kind of discussed a few of these, but in terms of the technical aspects of this, sometimes we see that, we don't recognize, or people don't recognize, health workers, that is, they don't recognize that consent is treatment specific. So, you don't say if someone does not give you consent to speak about their cancer, for example, but you have consent to talk about pain management. That's absolutely okay, because it's specific to a particular treatment. The other error that I have here is that sometimes we assume that there's a default treatment. So I wanted to emphasize here, there is no default treatment actually in healthcare. So for example, the examples that I give when I'm doing teaching is I speak about water. So if we have somebody who presents to the emergency department who's hyponatremic, we do not give them free water, in unlimited fashions, because then, obviously that could, create a problem. If somebody presents in hypercapnic respiratory failure to the emergency department, we do not just give them oxygen and, ramp up their oxygen, because that could actually kill them. And, if water and oxygen are not default treatments, then really nothing should be a default treatment. Those are just some of the examples that I give when I'm doing teaching. Another one that we often see is that the family is proposing treatment, or sometimes the resident, but sometimes, there's substitute decision maker, once again, is proposing the treatment. And a reminder, back to the previous slides, the role of a substitute decision maker is to share values, wishes, expectations, to obviously advocate for those wishes on behalf of the resident and not their own. So that's commonly an error where we see that, well, somebody's saying, well, I want my mother, for example, to have antibiotics, or, they have to have fluids, or you have to do this. And that's not how this should work. Obviously, I'm not saying that we should be, we shouldn't listen to people, and we shouldn't try to honor wishes, but we should take that further. And I can tell you, I've had many, many conversations, and this should be part of our routine practice, where we, instead of, trying to just blindly just sort of say, yes, we're giving antibiotics or we're giving fluids, even though it might not be the right treatment, we would then sit down and be like, well, why do you want to give antibiotics? What are you worried about? And sometimes or definitely a lot of the time, actually, I've been in situations where someone will say, well, I'm worried about, this so-and-so. And I might then say, well, okay, well, this is actually the right treatment that we can do to meet that, expectation and that very important, sort of thing you told me. I remember one conversation where somebody was full code, and actually, sadly, this is in a long-term care home that I worked in, which had a large-scale COVID-19 outbreak, and there was a very, obviously an elderly resident with end-stage advanced dementia who was actively dying, who was full code. And I spoke to the substitute decision maker, and they said that, well, they wanted their loved one, in this case, their father, to be full code because they were worried that otherwise they wouldn't get oxygen. And when I clarified that absolutely that was not the case, we would provide oxygen, we would make sure that they would not suffer and they would have relief from their shortness of breath, then they were completely okay with it. So that is one sort of example to understand how we should not just be honoring or just blindly listening to and following what a family member proposes, but we should be sitting down with people and trying to get behind what's that request. And then the last one is sort of assuming that consent is required to not provide a treatment. So remember that you need consent to initiate a treatment, but if you're not initiating a treatment because it's not clinically indicated, it's not evidence-based, it's not the right thing, you don't require consent, right? So if you feel that, for example, hydration is not clinically indicated, you don't need consent. So of course, somebody's asking for it. I feel it's all of our duty to, once again, develop rapport, do the things that David was mentioning, sit down with people, speak to them compassionately. All that is very important, but you don't need to do it in the end. Some of the other things, and we'll talk a little bit about this in the next few slides, but once again, following this one size fits all approach. So this is not like a standardized type of thing. It's not like we just discuss this the same way with everyone. And once again, I'll talk about this in the next few slides. Once again, David very rightfully so alluded to this, that, often, and I will say from the physician perspective, definitely I see that physicians are a little bit more guilty of just kind of focusing on their own agenda, getting their own tick boxes done, getting that code status done. And with that, that may not align at all with the resident's agenda or what the substitute decision maker wants to speak about. And really, we have to remember, once again, care is a relationship. This should be about connection before content, always. So try to develop the human connection first. A few of the things that we've already, I think, covered, which is sort of, deferring goals of care conversations to the end of life, or perhaps not recognizing, the importance of them. Well, that's maybe an obvious one. And I hope we would all realize that, because that's why we're all here. And then the last one is sort of, maybe not involving other colleagues as well. So of course, I know working in long-term care, especially if you only work in long-term care, it definitely can feel quite isolating. But I hope that many of you have other, colleagues that you can rely on in the long-term care home. So it's not just, all the burden of this is on you all the time. I hope that you have access to other specialists who can be involved in the conversation, to an ethicist, for example. And those are definitely sort of situations that, I see happening in long-term care, but perhaps not enough, where we can involve other members of the interprofessional team a lot more. Okay, so moving on, we're already 40 minutes into our talk today, but this is sort of, another example. Once again, identifier is removed, but I'll just give you the general idea. So this is a 90-year-old South Asian lady who has advanced dementia living in long-term care, and she's just tested COVID positive. And I'm talking about during the 7th wave recently. So she has 4 doses of the COVID-19 vaccine. She receives Paxlovid, but unfortunately she has a decline in health still. And she becomes delirious. Her appetite is reduced, and there was a DNR order on the chart, but then this is now revoked, by the power of attorney who is the daughter of the patient. And, the daughter actually says that she has other family members who are speaking to her about this and are very worried about the mother. They're very worried that, we're going to be giving up if we just sort of write a DNR order on the chart, and sort of speaks about the importance of consulting family members. There's family members who also don't live in Canada and live in India. And they also sort of say that, and this was sort of a circumstance where there was actually a new physician involved, but there was a mistrust with the previous physician who was working in long-term care. And they were, they kind of expressed that. And they said that, well, the previous physician had written off her mother many times. And that's where they kind of felt that, they didn't want to proceed with the DNR order. So, asking you again, have you been involved in some of these situations? Definitely during, I'm sort of referencing the 7th wave, but I think really during any COVID-19 situation, it puts a lot more pressure on people. Of course, it's better than it was in wave 1, undoubtedly, but, it just sort of increases social isolation and, makes people sicker in general, increases understaffing sometimes. So it once again puts the whole, system under a little bit more stress even now. But are these situations that you've seen or been in your practice? Okay, I will keep on moving, but once again, feel free to interrupt. Feel free at any time to put things in the chat. And I think, okay, I don't think I missed any comments in the chat. Yeah, thank you. But yeah, please keep it coming in the chat. So I just wanted to share that once again, care across our healthcare system is not provided equitably. We know that there are certain groups, certain communities which do not receive proper access to long-term care, for example. We're here to talk about long-term care, of course, today. I'm not going to talk about other aspects. But yeah, we know, for example, and this is not up on the slide, but I can tell you there was a study that was done here in Ontario, which showed that recent immigrants face much longer waiting times to long-term care. They also have higher levels of caregiver burnout. Residents who are recent immigrants who are admitted to long-term care are, sort of more likely to be sicker and have higher levels of disability. This particular study looked at Ontario nursing home once again and looked at DNR and DNH orders, so do not resuscitate and do not hospitalize orders. And they actually found, as part of a subgroup analysis in the study, that residents who spoke English and French, allophones and francophones, were much more likely to have a DNR or DNH order compared to allophones. So I mentioned anglophones and francophones, much more likely to have these orders compared to allophones, meaning non-English, non-French speakers. And often, because we don't collect race-based data here in Canada, we use other things as surrogates. And in this study, they looked at, what language people were speaking. And what's interesting, when we look at the literature at large around, racialized communities and how they receive palliative care in a setting like long-term care, and even outside, we find that actually it's not that people at heart don't want to be comfortable at the end of life. It's not that people are hoping to be in the ICU, but once again, there is a mistrust in the healthcare system. There's a mistrust in health workers. As I'm going to speak about, sometimes there's this way that we communicate with people where we think it works well with certain communities, and it actually doesn't work well with other communities. It can totally backfire, and that's something that we have to recognize. And the onus is on us to provide equitable care to really everyone that we can to the best of our ability, because we have to remember that, this is sort of very, very important, and it affects outcomes for our residents. So, there's many, many factors to this, but, and sometimes I'll also add that there are systems level disparities as well, which I will speak about. Sharon here is sort of speaking about Sharon. So thank you for joining us today. You're a nurse, and it's hard to change physicians in long-term care with families. All physicians do a great job, but maybe COVID has challenged this relationship. Yes, absolutely, that's true. And I remember also, even in the early days, of the pandemic, wave 1 and wave 2, and thankfully, I hope we'll never ever have to see those things again. But what was horrible, as with that part, as you might all remember, is that families were locked out and they couldn't even see their loved ones, and that created a lot of challenges in my experience, where they couldn't actually see the decline for themselves, and they didn't really know what was happening. And that created lots of problems with respect to goals of care conversations. And we know that families are essential care partners and should intimately be involved with these conversations as part of the healthcare team. So basically what I'm saying, one size fits all doesn't work. That's not what we should be doing. And we should be thinking about this in terms of the platinum rule. Sometimes we kind of practice in terms of the golden rule, which means we're trying to treat other people as we would want to be treated, or maybe as our loved ones would want to be treated. But that's actually not what we should be doing. We should be treating people and providing people the care that they deserve, which might be very different for different communities, for different people. So for example, if you're having a goals of care conversation with someone who is quite privileged, someone who has, it comes from a higher socioeconomic status, someone who speaks English, who has very excellent family support, family is very understanding and experienced, you might have that conversation very differently with another person who is a residential school survivor. You might have, this conversation very differently with someone who's experienced homelessness and trauma, somebody who's very socially isolated and has actually no family members, someone who's a refugee or used to be a refugee and is an immigrant to Canada and doesn't speak English and maybe used to having these conversations in a very different fashion. So once again, and I would also say not just the way you have the conversation, but the time and resources that you provide different individuals should be different, because different people's care needs are different. They are not the same. And that's the difference between equality and equity. So how do we define cultural safety? I mean, I have this sort of on the slide because we want to have goals of care conversations in a culturally safe manner. I will leave this definition up for you to read. I'm once again not here to provide a didactic presentation, but ideally we would like an environment when we're having goals of care conversations, when we're having palliative care conversations, when we're in long-term care, where residents don't face discrimination, either overt or covert, and obviously where people feel safe when receiving care. And once again, re-emphasizing that point that David brought up, that safety, trust, all of these things are so important and are at the core of having these conversations. And also, once again, we have to recognize that there is undoubtedly a power imbalance in these situations between us as health workers, especially from the physician perspective, and somebody who's very vulnerable. Once again, a lot of these people are very sick. Many people have dementia. Their caregivers are inherently burnt out. So there's inherently a power difference that often occurs in these situations as well. And we have to recognize that, and in fact, empower residents and families to make the right decisions within the decision-making framework that we have. Just sharing here a tool which I've come across that you can all sort of use on, and once again, these slides, as far as I know, will be shared with you. So this is a tool called the ABCDE tool, which can be helpful to provide culturally safe care. So, A stands for attitudes. So once again, important before you go into this conversation to think about, what kind of like perceptions do people belong to this cultural group? And once again, we don't want to stereotype. People are all individuals, but just to learn a little bit about somebody's culture in a humble fashion, it's good to understand, how do people discuss serious illness? What are the words they use? How do they discuss death and dying? In terms of beliefs, I mean, that may be applicable to people who have strong religious beliefs. Do people believe in miracles? Do they believe in an afterlife? What is the meaning of death? Context, so that's very important. So thinking about not just the resident as someone with a disease process underway, but thinking about them as a human being, learning about their background, the historical and political context, is very important. And I can share with you that we know here in Canada, we were talking about immigration, for example, and recent immigrants are actually much less likely to receive a palliative care approach. Refugees, even less likely so. And once again, it comes back to that mistrust, and it's very important for us to recognize this. Decision-making is another sort of phenomenon. And here in Canada, generally we focus a lot on resident-centered care, patient-centered care. It's very much autonomy focused, which is really a phenomenon limited to North America, Northern and Western Europe, and it's not really how the rest of the world commonly makes decisions. So the rest of the world actually commonly makes decisions in a family-centric manner, and in a family-centric manner. And often, these conversations are about softening the blow on the person who is suffering, perhaps even speaking about illness and disease very indirectly, so that that person can just focus on, living their life, and, their family members often children, for example, can deal with the hard decisions about, what to do next and, what type of care decisions need to be made. So that's something we have to ask ourselves. Are we comfortable working in this collective decision-making model rather than just a resident-focused model? And then, the last point is important, which is the environment. So obviously, I mean, if someone is living in poverty, they don't have family, these things are obviously very important in terms of the context of how we're having these
If you walk up to the car with me, we might be able to get
Well, yeah, we'll go.
through
I
the
can
place.
just
Sorry.
take-
Sorry, can we ask you to put it on mute, please? Okay, we'll move on. Okay, so here are some practical tips in terms of how we can provide culturally safe care in long-term care. And I hope the first one is pretty obvious, which is obviously using the professional interpretation services. So that is absolutely the bare minimum we should be doing when we're having these conversations. We should not be trying to get by if someone's first language is not English. And of course, there's many circumstances. I don't know what you've seen, but I've definitely seen many circumstances. In fact, all the time, where someone with dementia may forget English if English is not their first language, and may revert back to speaking their first language, not English, and they may actually be reasonably capable of telling us about their values, beliefs, and expectations, about reiterating what they're hoping for with future treatments. And that's very important for us to understand and for us to honor and acknowledge. I will share with you that there is actually a myth that obviously using professional interpretation services takes more time, but there is actually research which shows that if we use them, and obviously this counts on us having ready access to them quickly, then actually it doesn't really take longer in terms of having the conversation. And obviously it's a big safety issue. You can look up, recently there was a study that came out in CMAG, which in the Canadian Medical Association Journal, which showed that basically, sort of people who were frail and receiving home care, similar to the long-term care population, I would surmise, when these people were admitted into hospitals, if they had a physician who spoke the same language as them, and once again, we're speaking about non-English, non-French speakers, if they had a physician in the hospital who spoke the same language as them, then their mortality rate was 50% less. 50%. A huge number, which once again shows us that this is, a safety issue. So we have to use interpretation services. There's more to this, of course, that we have to think about how we're accommodating the needs of racialized communities with respect to many different aspects in how we build trust, whether it's, celebrating specific religious or cultural holidays, whether it's the food we provide. And we know that everyone does not all fit in the same sort of, type of care. They do not all need the same care. We need to provide individualized care, ideally wherever possible. We should be trying to review our hiring and training processes. Of course, if we have residents who belong to a specific ethnic or cultural community, and we have staff who also belong to that same community, we can surmise that the care would be a lot better. And I wanted to just sort of tell you that, trying to provide culturally safe care in long-term care is not just about attending a workshop or reading a book or, speaking about it once, but it's, ideally this should be incorporated into ongoing QI work. This should be something that should be a priority. Health equity should be a priority across our healthcare system, including in long-term care. And, definitely it makes a big impact when, leadership, senior leadership in long-term care facilities, actually, makes this a priority as well. But once again, I encourage you to think about some of these things from a QI lens as well. So moving on to the next section of our talk, where we're going to kind of focus on some of the systems level issues which impact goals of care discussions. So once again, sharing a case, a 95-year-old lady who's admitted in long-term care, who has dementia once again, and a breast mass. The family actually doesn't want any investigations, about the breast mass. They want her to actually be comfortable and receive, really a palliative care approach. They don't want reversible causes of decline, treated, and they want her to receive end-of-life care in the long-term care facility. She's generally quite comfortable, but unfortunately, what happens in this long-term care facility, once again, COVID-19 shows up, unfortunately, again, and there's an outbreak. There's some nurses who are off, who are isolating because they have COVID themselves. And then the resident's health starts to take a turn for the worse, likely because of the cancer. So the resident becomes delirious, becomes agitated and restless, and there's an agency nurse looking after, who's looking after the resident because the regular nurse is off and sick and isolating. And the agency nurse is, doesn't know the resident, is not really sure about, where to find the documentation, doesn't have that relationship, and calls 911 and transfers the resident to hospital. And unfortunately, the on-call physician was informed after the transfer had already occurred. And I'll share with you, when we asked the agency nurse, who kind of said, well, this is what I've seen happens in long-term care facilities. So is this something which has happened to you? Have you experienced this when working in long-term care? Have you seen variability in terms of how these situations are managed? I'm assuming yes. I'm assuming yes. So anyways, feel free to share any comments once again. So I just want you to think about this last case and think in general. Do you feel supported, or do your colleagues feel supported in having these discussions? What do you think the healthcare system can do better to provide better support to you to have these conversations? And Christine is writing, thank you, saying, I had a similar episode where a resident was transferred to hospital after a fall or suspected hip fracture. And yeah, that's something that's very concerning. And I mean, the question, I'm assuming you're sort of saying that there was an agency nurse once again. So do you think that would have happened if the regular nurse was sort of working? And, Christina said again, the resident unfortunately developed post-op delirium and died of aspiration pneumonia. Yeah, and that's something that I've definitely seen as well. And just kind of to elaborate on what Christina is saying, because it comes to my mind, even in terms of how we think about palliative care and the general palliative care framework, we almost need there's overlap, but it's different in long-term care, where in, I guess, palliative care, which historically is tied to cancer, we don't often talk about falls. And what's the palliative care approach to falls, which is not uncommon in long-term care? Do you have to always transfer to hospital where, someone will undoubtedly get a surgery and, as Christina's developed, may then die afterwards and may regret that decision? We don't often talk in detail as much about aspiration, is sort of another thing that we see very, very common in long-term care. But yes, this is something that's very, very important. Sharon is sort of saying, yes, it's important to document and communicate all conversations. That's very important. So sort of another comment that sort of says that, we track reasons for call with our after-hour calls group. Getting a call after the transfer is not uncommon, unfortunately. So I'm sad to hear that. In some way, I was hoping that there was an Ontario phenomenon, but it doesn't sound like it. And, I'll speak about some of the systems issues. I wanted to emphasize, I'm not blaming a particular health worker or the agency nurse in this situation. In fact, agency nurses themselves are quite precariously employed and have risk themselves. In fact, that's quite sad that our health workers that we work with, our interprofessional colleagues, are themselves at risk. And obviously I'm saying that from the physician perspective. Nicole is adding, clearly communicated goals of care needed in a place on chart where all of the team has ready access to it. So that's something, yeah, very, very important, that if you have access to the goals of care, they've already been communicated well, they can easily be accessed, even if there is an agency nurse. Yes, I think that would be a really good project and something that's very, very important. Thank you so much, Nicole, for sharing that. So some great conversations, some great discussions. We'll talk a little bit about systems issues now. And once again, we are not separate from the system. And that's where I know David was sharing his experience in the beginning, and I'll say it again. These situations are bound to happen actually when residents are unfortunately suffering, receiving inappropriate care. And I'm just being very honest about it. I'm not trying to be cynical. And these are related to the healthcare system. So even if we take it upon ourselves to do as much improvement as we can, we also need to improve the system in which we're working in. So here's this tweet, which I had from a while ago, which talked about just, taking a step back. How do we fund our long-term care and our home care systems in Canada? We call them sort of continuing care. And we fund them very poorly. Basically, that's the bottom line here. So other OECD countries do a much better job of funding elder care. Right now, there's a conversation about space in hospitals and alternate level of care patients. And many of those countries, especially those that have a properly funded home care system, such as Denmark, don't have that problem. They don't have people who are on huge wait lists for long-term care because they've simply put a lot more funding into home care. You can see here Canada is, roughly funding this sector around half of what these other countries are providing funding. And the vast majority of this funding is going towards building long-term care sort of institutions where people actually don't want to be. And we know this, of course, working in long-term care, that the preferences of seniors are not being honored by actually going into long-term care in the first place. And yeah, Kat brought up a good point here, which is that quiet privacy have these conversations is often lacking in some care homes. So yes, that's true. If you are working in an overcrowded sort of long-term care facility, residents often don't necessarily have private rooms. You may have residents who are sharing rooms. That obviously creates a lack of privacy, a lack of autonomy. That's something which is quite concerning as well. So obviously it can be harder to have these conversations for sure. But as you can see here on the slide, we are grossly underfunding this whole sector, and especially home care receives very little funding in our country. And one last comment about this, it's a lot more expensive to do this because actually we're ending up caring for these people anyways. When we have high rates of transfer to the hospital system is providing the care. And as we've mentioned and discussed today, often not so appropriate or not so adequate care as well. When we are just building more and more long-term care facilities and not funding home care, of course, it's way more expensive because with home care, obviously we're simply providing care to people in their own homes. But in long-term care, we have to buy land, we have to spend millions of dollars perhaps to build one big long-term care facility. And honestly, it's really impossible to individualize care. As much as I'm saying we should try to do it, it's impossible to do it to the best of our ability because of the fact that, like if you have 300 people living together under one roof, it's going to be hard to sort of meet one person's food preferences in that setting. So home care is really where people want to be. And I'll share with you, even the word and the way we use the word long-term care in Canada is very different than other countries. So in other countries, long-term care is like a verb. So what that means is it's not a place, it's a verb, and you can receive long-term care in your own home, which is really what the philosophy should move towards here as well. And, obviously we all know after what's happened with COVID, this is the time that governments should all be coming together to make this happen as our population rapidly ages. Okay, so moving on to, really goals of care conversations and why, often what are the systems issues that impact long-term care? Well, of course, we talked about staffing levels. Staffing levels are very, very low in long-term care. I mean, what I see when I work in long-term care, and I work at Kensington Gardens, which is a long-term care home in downtown Toronto, as I mentioned, and it's a not-for-profit long-term care home. It's actually one of the best, or it's known as one of the best in downtown Toronto. Our wait list is the longest in Toronto. We have the longest wait list. We don't pride ourselves on that, but I'm just telling you sort of a fact. We have one nurse looking after 25 residents in the day, and that drops down to 1 to 50 at night. And we know, as I mentioned, the acuity and complexity of these residents is much higher than it was 10 or 20 years ago. I can share with you, I was just speaking to, the vice president of Kensington, like maybe a week or two ago, and he was sharing with me when Kensington first started, which was, I believe, around 25 years ago, if I'm not wrong, there were some residents who were driving themselves in to be admitted into Kensington. And now, obviously, as I mentioned, we're seeing people who are being admitted and they're actually in their last months of life. So, of course, the system has completely changed in terms of the level of care that's required. We have poor working conditions, and that's something that's very important because sometimes we see then continuity of care is really interrupted. And once again, coming back to that very important experience, which is shared by David about his own personal experience about developing rapport, that's important for everyone working in long-term care across all interprofessional disciplines. Continuity of care, because care is a relationship. If you're an agency staff, and I can just imagine if I was an agency physician and somebody assigned me to work in a long-term care home for the next 5 days, I mean, I'd just be going in the first day and kind of just trying to understand what's even happening. I wouldn't even know, where certain residents are, how to best communicate with people. Maybe I wouldn't know the EMR. There's so many things that I would be learning. So obviously we can see it's not the fault of the agency staff. It's the fault of a system which kind of doesn't actually pay people well and doesn't actually fix issues with working conditions on the front lines. Short staffing itself, unfortunately, creates this vicious cycle where obviously if you're that nurse and you're working in a 1 to 25 or a 1 to 50 ratio at night, as I mentioned, well, maybe you'll be facing a lot more moral distress because your residents will be maybe waiting for care. In some cases, they'll be missing care, and then you're going to leave. right? There's this issue around equal pay for equal work as well, where we know that in long-term care, you're paid less as compared to working in the hospital, and home care is actually paid the least. So that's obviously an issue. And I can tell you, working in hospitals as well, I've talked to many people, many nurses, actually, my colleagues who used to work in long-term care, and they loved working in long-term care. They actually told me, and I'm quoting them, they said they loved their residents and they would actually go back there. But the issue is the affordability became a problem, that they actually couldn't afford to pay their bills. And that's what forced them to leave. And that's obviously not fair. We have to recognize that long-term care, honestly, is equally as important as hospital care. And the complexity, acuity, and the skill set that's required is also equally as important. And of course, bringing it back to our topic today, this affects goals of care discussions if you don't have continuity of care. We talked about that example of the agency staff. When you're stretched for time and you are sort of delivering medications to 25 other people, or maybe even like more people, and you have multiple residents who have needs, if you have one resident that needs you to sit down, have that conversation, reassure the family member, then get on the line with the physician and sort of have that goals of care conversation and negotiate that, well, it's not fair to expect you to do that all the time when you're so stretched to the max, and in fact overstretched. The other problem, which I've mentioned here, is that we're seeing in long-term care, the workforce is being de-skilled. So I mean, listen, I have nothing at all against PSWs, different levels of nurses, registered nurses, LPNs, RPNs, and so on. And, I'm not a nurse, so I'm not trying to in any way speak on behalf of the nursing community. But I can tell you that in general, I mean, we call these places nursing homes for a reason. So we definitely need a lot more nurses to be working in long-term care facilities, once again known as nursing homes. 1 to 30 or 1 to 25, as I mentioned here, is what I'm seeing in the day, and 1 to 50 at night simply doesn't cut it. And that's obviously a major problem. And if we don't improve staffing ratios, then it's going to be very hard to provide good care. The other issue that we see, and I think this was something that was being alluded to as well, is that, once again, they're on-call groups. And through my previous family medicine practice, I was part of these on-call groups too. And I remember that we would cover multiple long-term care facilities, not just our own long-term care facilities. And that was just something we did, honestly, to survive, so that we wouldn't be burnt out and wouldn't be on call so often. So what we would, this was often a circumstance where the MRP knew the resident very well, knew the family very well, was sitting down, having these conversations regularly, but then the on-call physician didn't know what was happening and kind of took the route of, I guess you can say, the path of least resistance, or sometimes even maybe a more cautious path where they were worried about, missing something. And sometimes that cautious path includes doing more. And that means sending to acute care, making sure that they have extra investigations, tests, and stuff done to them in the hospital, in spite of the fact that this might not have been the plan of care before. So that's something that we see. The other issue, and I was kind of alluding to this before, that, in long-term care, there's definitely unpredictable trajectories, and that cancer care model of palliative care doesn't work, where we have the hospice model where people are predictably declining from PPS 40, and then a few weeks later they're PPS 30, a few weeks later they're 20. That's not how it works, and we know that. We probably, this is the experience that I'm sharing with you. I care for a lot of residents in long-term care who are probably one complication away from death, where they simply need one fall, one aspiration, one critical infection, and at the very least, they'll be in a life-threatening situation or they will die. And there are lots of people actually living like that in the community, even outside of long-term care, and definitely inside long-term care as well. So it becomes very hard to predict when will that complication happen, because they are continuously living with risk. So that is definitely something that's an issue, and we have to learn to cope with uncertainty and this erratic trajectory a lot better. And we need to reframe how we think of palliative care. There's also a lack of confidence sometimes, and this is a cultural issue I find in long-term care, but I think it's driven by the understaffing and how poorly we treat health workers, especially our colleagues, nurses, PSWs, and so on, where sometimes there's a lack of confidence to provide appropriate symptom management. I've talked to many staff who have sort of experienced and seen bad deaths, a lot of suffering. So then maybe in those circumstances, people do feel, well, hey, this is not something that we want to touch. We're actually traumatized ourselves by dealing with this, and no one has talked to us. Nobody even cares because we don't have time to even speak about this or debrief as a team. So it's better to just send the person to the emergency department, and that's probably the better approach. And I don't blame those people in those circumstances. You know, and then the other issue, I think we've spoken about some of these issues before, is that, you know, this is often downloaded on long-term care facilities. It's downloaded in other places too, on like, say, the palliative care team in the hospital. And there's sometimes not enough attempt, or sometimes even no attempt made to discuss goals of care before the person who's arriving in long-term care. Ideally, we should be having all family physicians, geriatricians, other specialists, all being able to have these conversations. So when someone is initially even followed by a geriatric clinic, and they're having, they're meeting with a geriatrician on a regular basis to discuss, dementia care, and they're at like the mild or moderate stage of dementia prior to admission to long-term care, definitely then is the opportunity to discuss things. And I would add, it's ever so more important with an illness like dementia, where somebody will lose cognition and be unable to advocate for themselves eventually. It will probably take the burden off decision making, or make the burden easier for the substitute decision maker, where they would simply know that they would be honoring their loved one's wishes and they would not be guessing. So once again, very, very important. Moving into a little bit of depth about some of these systemic issues. So staffing levels, I mean, I'm not sure, what detail you know about this, but, it's really recommended by experts such as Dr. Pat Armstrong, who's one of the international researchers and national leaders in terms of long-term care, that we should be providing 4.5 hours of daily hands-on care per day in long-term care. And as far as I'm aware, there's really no long-term care facility in the country which meets this standard. And I know in Ontario, I can tell you that the government in 2025 has committed to actually have 4 hours of direct hands-on care per day, but their ratio is not correct, where they're mostly hiring PSWs, but not enough nurses. In fact, they are barely hiring enough nurses and doing enough to retain nurses as well. So this is basically a huge challenge. And, I see a comment here from Sharon. I love a bedside nursing, which is, I think, was where nurses live. And then a challenge can be providing a good orientation for staff in long-term care, giving them a feel for the unit. And that's actually very, very important. We need experienced nurses to actually stay on the job, or frankly, even come back in, across our healthcare system, including long-term care, because we know that obviously that will help so much in building that expertise and developing that mentorship. So important. And, I want to take this conversation around staffing levels beyond simply nurses and PSWs. I can share with you from what I see. I also see variable, physician support in terms of how many patients we have. We don't have that same overlap and that standard of care that we have in hospitals. So I can share with you, in hospitals, there's always somebody looking over, looking over my shoulder in terms of the care I'm providing while I was doing handover. But working in long-term care itself can be quite isolating, where you might be practicing on your own for many, many years, but you might not have that level of collaborativeness, that level of access to other specialists, as I mentioned. And, also when we're talking about staff, this just does not mean, sort of healthcare staff. There's many, many other people who are equally important, and arguably even more important than doctors, nurses, and PSWs. And that is sort of recreation therapists, social work, spiritual care, trying to provide people activities, activation coordinators, because, once again, this is supposed to be someone's home. It's not really primarily supposed to be just a medical facility. I really feel that the medical needs should just be a given in terms of PSWs and nurses. And we should be aiming to provide people not just life and keeping them alive, but quality of life should really be the focus. But once again, we need enough staff in terms of how this happens. And I'm seeing a comment here from Teresa Martel. I would support a nurse model review. This would attract more nurses. It would then be satisfying to come to work. We know what we would like to do. We know what we would like to do, but we struggle to find time to do it. I believe it would pay off in terms of quality, care planning, and prevention. It's almost cheaper to apologize now. So very true, Teresa, thank you. So this is just a comment. I mean, I can just share with you, I shared with you the ratios in terms of our long-term care facility. And we have a hospice actually right next door to our long-term care facility. I would actually say that working in a hospice is a little easier because the goals of care are already established by the time somebody arrives in hospice. Everybody is receiving end-of-life care. The acuity is very different, but in hospice, we have one nurse who is specialty trained in palliative care. The ratio is 1 to 5, and there's a physician there actually every day because this is in downtown Toronto. So, I mean, this actually shows you some of the discrepancies and the disparities which exist in our healthcare system. We know that, of course, In terms of nurses, once again, I want to emphasize that, there's recent surveys which show us that we're in a crisis with respect to nursing shortages. And this is not just in our emergency departments, but really everywhere. 75% of nurses actually in our country are burnt out. There's many who actually plan to leave their position, and actually a significant proportion who plan to leave the profession altogether. So this is a crisis, and we need to address this immediately. This will undoubtedly impact the quality of care that we provide. I'm sharing this slide with you from a PSW perspective. PSWs are perhaps the most frontline health workers in long-term care, who know their residents inside and out, who provide the most intimate care. And this was a campaign that was done by Unifor in Ontario, actually before the pandemic, I believe in 2018, which was called the 6-Minute Challenge. And basically they did a study which found that an average PSW in Ontario had 6 minutes to get their, their resident, or a resident ready for breakfast. So that meant getting them out of bed, getting, grooming, changing their incontinence brief and all of that. And really this challenge was, if we can't get ready in 6 minutes, well, how can we expect, a PSW to get their frail, older person that they're looking after, who's perhaps has many, many more complex needs? How can we expect that to happen? So this shows you how stretched care is. And once again, emphasizing goals of care conversations are interprofessional. I've been in many goals of care conversations where absolutely PSWs have played a critical role in sort of helping to sort of speak about quality of life, helping to speak about pain and suffering, helping to speak about, moments that provide a resident enjoyment, what makes life living. And obviously all those things are very, very important when making treatment decisions. So speaking a little bit more about working conditions, and I'm just coming to the last few slides of my talk, by the way, we talked a little bit about fair wages. We talked about equal pay for equal work, where you should be getting paid the same to look after a similar patient across the healthcare system. Ideally, people should not be cobbling together multiple part-time jobs to make a living, which generally is what we see in long-term care, where people don't have, or not enough people have full-time jobs, not enough people have permanent jobs. And once again, those jobs are not well paid. We have to also look at our current context with inflation being very high. Ideally, because of continuity of care, we would have people, this is the advantage of having a permanent job and a full-time job, is that you wouldn't be working for an agency, but you would be working at a single long-term care facility. So you would know the residents, you would have that relationship, and that would undoubtedly help with having goals of care discussions. And of course, there's a big issue, let's recognize this, with actually workplace violence for many, especially nurses and PSWs in long-term care. And one of the major contributors to this is because of the fact that residents are waiting for care because they are stretched. It's not the fault of the PSWs or the nurses, it's because there are just so few of them working within the system. And Sharon is making some comments here that says, quality of life, we shouldn't be running long-term care like a subacute facility. Let's celebrate, so I'm trying to understand this. Let's celebrate the care of all your colleges every day. There's a project I'm seeing in Island Health, which is called the Hope Project, each month since July. So Sharon, I hope you'll share some information about the Hope Project. So, just for me, I'm assuming everyone else kind of understands what that is. Here's another slide that speaks about education and training, around palliative care and, also around goals of care. So we know that medical students, residents actually don't have enough training around this. This graph, the bottom sort of, curve or whatever shows us that actually, this is actually the percentage of responding schools. But basically, I'll just summarize this. I won't get into the details of this graph in terms of time, but, actually in our country, even now, you can become a family doctor, and family medicine is supposed to be cradle to grave. It should be, but you can even become a geriatrician. You can become an oncologist. You can become an internist, and not all programs actually include palliative care training. Also, when I speak to my nursing colleagues, nursing school does not include palliative care training. So sometimes we have situations, undoubtedly, where well-meaning physicians, well-meaning nurses just want to provide good care, but are learning on the job. They don't often know where to turn to with respect to training, and it takes time, obviously, to do this work. And you're already in medical practice and you're already practicing, it's a lot harder, obviously a lot easier to learn the right way rather than having to unlearn inaccurate or bad ways of practicing, for lack of better wording around that. But basically, obviously, if we educate all health workers around a palliative care approach, having good quality goals of care discussions, we would expect this to change across the healthcare system, including long-term care, and it would be a lot better. And that should be something that is done. I kind of mentioned how family caregivers are a very, very important part of the healthcare team, and they need to be included in in these conversations as well. But it's more than that. I think we need to do a lot more to recognize the labor that actually essential caregivers, most of whom are women, actually provide on an unpaid basis in long-term care facilities. In my practice, and I'm sure in yours, I mean, I see on a regular basis that family members, once again, mostly women, are coming in and feeding their loved ones. They're assisting with translation. They're, helping with goals of care conversations, for example. They're, helping their, like their loved one, often a parent or a spouse, for example, to take medications. So this is something that is very important. And if we had a better resource system, we would be providing a lot more in terms of caregiver supports for emotional counseling, psychosocial support, grief and bereavement. And once again, this would start before someone arrives in long-term care, because often, not always, but often in my experience, I do see that, one of the reasons that people get admitted into long-term care and end up in hospital, which then, sort of ends up in a long-term care transfer, is because we have a caregiver that's absolutely burnt out and unsupported due to complete lack of home care funding. So that's something that we have to address. And if we don't have burnt out caregivers all the time, or as much of the time, obviously that will lead to a lot more collaboration and consensus around these decisions. And then one thing I spoke about, I mean, I strongly believe, once again, that, your address or your location within the healthcare system should not determine the quality of care that you receive, but yet that is an issue. It should not determine your access to any type of healthcare resource, especially with the onset of virtual care nowadays. Obviously, that's not the same as an in-person assessment, but it is definitely something which can be used very appropriately, and in many circumstances, reduce access barriers. So, I strongly think that obviously anybody living in long-term care should have access to a palliative care specialist. As frontline health workers, really, who are part of the primary care team in long-term care, you should have access to, a specialist to help guide you if you have questions, if you have concerns. But often we see how palliative care is delivered in this country. It's delivered in a patchwork fashion. It's very much underfunded. There are, the care is regimented, where palliative care teams will have rationing of care, where they will say, we will only, accept patients based on a specific criteria, even though we talked about the broad definition of palliative care, which is very different. And often, what I often see is that even if someone was followed by a palliative care specialist and maybe has needs which are more complex, and I'm not saying that, of course, primary care physicians, nurses, social workers, nurse practitioners don't provide good palliative care, but I'm saying that palliative care specialists have an opportunity to collaborate, perhaps in some more complex cases, to be consulted where there's refractory pain and symptoms, to be consulted where there are sort of ethical challenges with respect to goals of care, to provide an extra layer of support. That's what I'm saying. But, that access should be available for, long-term care facilities in general. And yet that's not the case. And we know that, of course, this can improve outcomes, as you can see here from the slide. So that's it. I just wanted to kind of give you sort of a broad discussion around goals of care. I didn't want to focus on just the technique around having goals of care conversations, because I'm sure you're all very experienced in the technique, but I wanted to talk a little bit about some of the nuances, how we can do a little bit better, some of the errors that we should remember and when we're having goals of care conversations, how we can deliver goals of care conversations more equitably, and how hopefully our healthcare system can support us better when, and support our teams better with having these conversations. And
That was wonderful. Thank you so much. So yeah, if anyone has any questions, please feel free to ask away.
And I can't type in the chat for some reason, because it just says host and panelists, and it doesn't allow me to type. But I just wanted to thank all of you as well for attending today, and it was lovely to be a part of this and to, I guess, connect with you, albeit virtually.
Any questions or comments from the group? Kat, you've unmuted yourself. Do you have something you wanted to say?
Hi, I think I'm muted. Sorry.
You're unmuted, Kat. Yes, we can hear you.
Great. Okay. I guess one of the things that I struggle with is when a family member wants CPR for someone who is, totally in a, well, not clinically indicated in any way, shape, or form, and pulling them back from that ledge.
Yeah, so that's often, a concern, and I can share with you, I mean, it's a complicated conversation. Probably you could have a talk one day for your seminar series exclusively focused on CPR. That's definitely something you could explore, and in terms of like bioethics and so on. Once again, if we think about, I guess the paradigm that I presented today, from a systems level perspective, I would argue that ideally, we shouldn't be like, the burden of having these conversations should not be just on us. So ideally, there should be conversations before long-term care. And even thinking more broadly, we need a public health campaign. We all understand public health now with COVID-19, and how we've done well in certain things with respect to public health at earlier phases of the pandemic. So we need a public health campaign as our population ages to inform people about advanced care planning, death and dying, about how CPR is not what it appears to be on like television and shows like Baywatch. So that's something which should be done, which is, in a way, a systems level issue. I think in terms of the care you're providing and the direct care, I understand some of the challenges. And I can just share with you briefly, I'm not sure on a personal level what the legislation is like in British Columbia, but in Ontario, I can tell you that actually right now, the rules are that you cannot document a DNR order without consent from the substitute decision maker if the resident is incapable, or a resident directly. That is kind of the rule. There's a rare exception that if you, and I'm not sure if your role, sorry, Kat, but if a physician, is at the bedside at the time of the arrest, they can then say, well, this is not within the standard of care and the arrest won't happen. But physicians are almost never at the bedside, to be honest. Even at the hospital, it's nurses who are usually initiating CPR. And in the community, in long-term care, of course, it's nurses and PSWs who would be initiating. And then maybe a physician can make the decision to discontinue. But anyways, to make this sort of long story a little bit shorter, is that here in Ontario, they are changing the legislation around CPR. So actually, there's a new policy that is being put forward or being reviewed now in public consultation phase, which will actually make CPR like any other treatment, which means that, just like as physicians, we actually often make decisions. And I presented this as one of the slides where you don't need consent to not provide a treatment. And you should not be sort of honoring near impossible requests. And right now in Ontario, CPR is unfortunately the exception, but this new legislation or this new policy from the CPSO will bring CPR back in line with what it should be, where essentially you will be able to go to someone and you will be able to explain hopefully in a kind and compassionate manner, just like you would say, we're not offering surgery, we're not offering dialysis, we're not offering chemotherapy. In other situations, you'll be able to say, well, we're not offering CPR and it's not indicated and it's going to cause more harm and suffering. So this is what we're doing.
Great, thank you.
Any other questions or comments from anyone?
I have a
Thank you again. Oh, yep, go.
Sorry, it's a very quick comment. Just in Victoria, we have shortage, like a big shortage of family physicians. So we have tons of people who do not have access to the doctor. And of course, our clinics overloaded. And it's very difficult because access to any care is via family physician. So this whole continuity of care, like it's everywhere. And like, I really hope, obviously there's complicated solutions. The whole system needs to be rethought, but it's the communication pieces, right? Because you can have a person seeing all these different people and nobody talks to each other, right? Like there's no communication system which is the same, and therefore you may have that conversation at one level, but it doesn't get anywhere. And I find like that's one of the biggest problems. It doesn't matter how many people are involved, but it's probably very the same across the country, to be honest. So that's my only comment here.
Yeah, thank you for sharing that, Sasha. I appreciate that, and I feel what you're saying. That in a way, it seems that now in the place where the healthcare system is, and you mentioned shortage of primary care providers, which is undoubtedly something that is happening across the country. I also spoke about a nursing shortage as well. I mean, things are very, very stretched, and communication often becomes worse. There's more likelihood for errors, and I often find that the only way that or more and more often now, the way that things get done is for someone who is, obviously very compassionate, but, has to put in that extra effort now to kind of go out of their way to, create a care plan or make that extra phone call, because otherwise things won't happen. And sadly, that's becoming more and more, it's just becoming more and more common that we're relying on, I guess, the extra compassion and a health worker going above and beyond. Okay.
Hi there.
Sharon?
It's Sharon, the RN. Thank you very much. I've been a nurse for 35 years, and to hear this kind of presentation just is so close to my heart. I would recommend all of my colleagues take hospice courses, because at least it starts the dialogue and helps us looking at our own deaths that we would like in order to help our own residents and families with their journey. That is our thing, is to support a journey, and it's not our journey, it's their journey. And thank you very, very much. I have really enjoyed your conversation and your dialogue, and will share it with my colleagues at Island Health.
Thank you so much, Sharon. Really appreciate your experience, and thank you so much for your kind comments.
Okay, well, thank you so much. We really, really appreciate you taking the time today and coming to be a part of this presentation. Thank you again. Hope everyone has a wonderful evening.